So is using intermittent saline going to be the cure-all when it comes to looking at dysautonomic type of findings in people that have ME/CFS? That's the big question, right? And so that's the question for today. And we're talking about this analysis of a paper that was written by Sjogren, just came out in July. So it just kind of got rolling. And they're looking at intermittent IV saline usage in myalgia encephalitis, chronic fatigue syndrome, in people that also meet the criteria for dysautonomia. What is the criteria for dysautonomia? We're going to talk about that as well. This is the paper right here. You can see it. It's a publicly available paper, so anybody can go and read it. I invite you all to do that because I think it's a worthwhile read. But what I'm going to do is actually go through an analysis, and I'll just walk you through the way I do it when I'm reading the paper and some of the things that I think stick out for me. The way the title's written, Beneficial Effects of Intermittent Intravenous Saline Infusion in Dysautonomic Patients with ME/CFS, a Case Series. So right off the bat, the title's kind of indicating like that there's a benefit to using IV saline in these people. Then the question is like, to what degree, how much, where do we go from there? So that's kind of what we're going to go through here. We'll just start kind of moving through the paper. So the background, real simple, just a basic introduction. We're just talking about the prevalence, the burden. Most of the people that are in this conversation know all about that, and you're mostly concerned about your particular burden. And I think one of the things that's really important is that they were kind of starting from this prior evidence that said, hey, acute saline seems to improve some orthostatic symptoms in people that have orthostatic intolerance. And then in the 2015 Heart Rhythm Society recommendations, they actually recommended against using long-term IV saline because of dependency issues. That was kind of what they were talking about back then. And I think where this kind of interface is you see this correlation, or our little Venn diagram here, of orthostatic intolerance. We're going to call it POTS here because it's kind of the criteria they were using in this case. But what we think about is, what is the overlap between POTS and ME/CFS? And most of the vast literature seems to point around this idea of cerebral hypoperfusion, not getting enough blood flow to the brain, and hypocapnia, which is a decreased level of circulating CO2 dissolved in the blood, or carbon dioxide that's dissolved in the blood. And so if you kind of start from there, and then we look at that in terms of how are those feedbacks operating together, and then we're going to try to weave in and understand how would IV saline be a useful tool for those people. So what they were trying to figure out was whether or not it's feasible. This is just kind of like trying to get some signal. So you're doing a small cohort of people. You're going to try to see, is there something here? And then does that warrant further investigation? What they were doing in the study, it's a 9-week study. And they did every third week, they do an infusion. So we've got basically 3 infusions over the course of 9 weeks. And so they originally enrolled 40 patients. And of those 40 people, they had 22 that completed all 3 IV sessions. And then of those 22, 19 of them completed the follow-up questionnaires that go with it. And then 17 were included where they actually had the data that they used to kind of measure their effects were largely questionnaire data. So it's kind of like, how are you feeling data? And unfortunately, like that's kind of a tough data set because how you're feeling may not fully correlate day to day purely based on what we're trying to measure here, right? So like, for example, your hydration level may be completely normal, but you have a headache because someone punched you in the face yesterday. Not a good example for these cases, but you can see where you're not able to isolate it down to one variable when you do it in kind of a subjective study where it's like, how you feeling today? Anyway, so that's kind of where we're at. They just use a simple sodium chloride, just a simple saline solution infused over 3 hours every 3 weeks. And the volume that they're putting in is about 1.6 liters, which this was, this is kind of basically what you'll see. But the thing that always kind of catches my eye when I look at this is the fact that 1.6 liters, you only have like 5 liters of blood in the body. And so if you're putting an extra 1.6 in, you're expanding. That's like a third of your normal blood volume that you're adding in. So it's like you're really pumping up the system here. And the reason I like to look at these studies is because we're saying, basically someone's saying, if we just load the vessels up, does that help people feel better, number one? And does it normalize any of the functionality, number two, right? So obviously, if you hyper expand the blood volume, eventually your kidneys are going to catch on to this game and they're going to start trying to get that fluid back out again. So the real question is, by expanding the volume, do we see changes in the overall systemic function that persist over time? And that kind of becomes the main question that people want to know when they look at this stuff. So what they did for outcomes and measurements, they did this composite symptom score. You can rate it 0 out of 96, but they basically gave you like, 0 is nothing, 1 is mild, 4 is unbearable, and it's score it, but they give you a multiple on each one. So if you rate a couple things a 4, that's like your number times 4 or times 1 or times 2 or times 3. So it's not a validated score. It does include a lot of the common symptoms that happen in ME/CFS, which is cool. But it's probably not the best way to really judge effect, simply because two things we talked about, just keep it real simple, is that we're looking at subjective scoring. So it's kind of like, how are you feeling? And that can be influenced by multiple things, especially since we don't have any sort of a control group or any sort of placebo study. So it's really just based on like, what are vibes going on? How are you feeling as a consequence of, being here and getting an IV solution. And then they did a MAPS score, and then a quality of life score. Again, these are all just kind of like questionnaires you fill out. They did measure heart rate, blood pressure, SpO2, and then just a bioimpedance hydration, which is, you step on, the scales that have the little plates on them. You can get them now even on Amazon, but they've got the little metal pieces on them, and you stand on it and it gives you an estimate of your hydration. Cool. They measured that too. And when they looked at it, everybody was kind of in the normal range on hydration according to that Tanita scale. And then they did a tilt retest. One of the things that was unclear to me when I read this study, though, was that I wasn't really certain that when we were looking at the original tilt test, that it was done immediately prior to starting this. The original one, I do believe, was anywhere up to like 3 years beforehand. I could be corrected on that. If somebody has the supplement data, that'd be really helpful. I wasn't able to find that yet. And it was unclear with how the story was written as to when that initial tilt table was done. But we know that the final tilt test was done somewhere within 2 weeks after the last saline infusion, on average about 9 days. Remember, we've only got 22 people that did this, and only 17 of them were able to do the tilt test afterwards. So we only have really 17 people, which is not nothing. It's a good number, but we only have 17 that were able to kind of like run through the whole gamut when we started out of the 40 that we started with. Okay. So, and this is kind of the composite system. So when you look at it graphed out, let me pull it up here for you. You can kind of see this line at the bottom is like kind of taking that symptom score set, and you add all the numbers up, and it's like, this is kind of about how everybody felt at the beginning. And then over time, you see that number, it looks like their perceived symptoms are getting a little better. Now, if you got 17 people or 22 people, this is an interesting way to present the data. So with 17 people, that's not a ton. So normally the way that you would do this is so as we're looking at this, you're taking everybody's scores and basically adding them up and averaging them out. But every individual score could have a way different variation. So if person A or patient A goes from, like, let's say a 55 to a 2, that's very significant, and may have an effect on how that person actually feels in a way that changes the way they operate in the world. And that becomes like a useful understanding of like how much change is actually necessary for someone to feel better. So like, as you look at these numbers, if you're someone that has ME/CFS and you're like, sweet, what number do I have to get to go like back to work and like doing my life again? Like what is the cutoff? So the hard thing about the composite scoring is it doesn't really give you anything that tells you like how are we really doing. It's just a like more of a sense of the sentiment, or like how are we feeling. And the way that we should probably do this graph is actually using something that is tracking each individual person and how they do over each of those assessments. So, because it's only 4 plots for each person, and then you just draw them out like line graphs. They usually call them a spaghetti plot, but it kind of would look like, you just out like this, and each person, is going to tell you how you feel, and then you can correlate their individual lines, and you can watch how each person is doing, and you can line that up, and you can see where the trends are. So that's probably the way this data should be presented, because that gives you a better sense of like per person, what are we seeing in the changes week to week. So I think that would actually be more interesting to look at. Perhaps when they publish the supplementary data, we'll just plot that out, and maybe we can put that up too. Anyway, so you see this, it's enough to have an effect size when you put everybody together, which makes me kind of wonder though, if you look at everybody individually, does it kind of show the same, do you get kind of the same level of excitement out of that? So this is kind of what it looks like. So we see here, they looked at kind of across the board. I'll show you what this looks like graphically. They look at all 3 of these different kind of scoring things they put together. So we've got the POTS related scoring here in the before and after. So these are whisker plots. So you see like where the mean is in the middle, and then kind of where the standard distribution is, and then where the long tails are on the outsides. And you're just kind of looking at where they tend to clump together. Again, this might be something that would be better to look at the actual individual scoring rather than lumping them together like this. But this is probably the way that makes it look the best. So the POTS score, we can see that the POTS score, we get a decrease afterwards. Quality of life has a tick up here. And in the working ability, you can see that the overall box, so this is like a 0 to 100. It's kind of a strange scale. It's like a 0 to 100, with 100 being like I could go back to work. So this is a tough one to read, because it's like most people are like, well, yeah, I can't go back to work. That's why I'm enrolled in this ME/CFS study 3 times, or once every 3 weeks, of trying to get better again. So that's already going to select for people that are going to be super low. But even though it looks like we have somebody here that must have been working, because they had, 100 here. And then at the end, though, we don't have anybody that's in that scale. So that's kind of interesting. Again, this would be another one where you'd want to look at individually, how are all these people doing, and actually pulling it apart like a case. So you could look step by step through each of these cases and parse the data. That's more useful, because then you can actually understand like, well, in this subset of people didn't do so great, but in these couple of people, it was awesome. What makes it awesome for them? And then that's where the investigation could go, which might be a good way to look at it too. So anyway, that's what we have there. And then the physiological measurements, this is kind of what becomes a little bit more interesting, because obviously, like, here's the thing. So if you have people that you're just introducing saline into their lives, and you're expanding their blood volume, you're going to make them feel more hydrated. And to some degree, for a large number of people, that's going to just like feel good in general. So you can take normal people, give them saline, and they kind of feel a little peppier, right? I had some friends back in the olden days when I was a degenerate young man. I didn't do this, but they used to go to Las Vegas and go gamble all night. And then they had the ability to take saline bags, and they would do their own saline bags in the hotel rooms. to recover and then get back to it the next day, right? So these are people that obviously don't have this type of condition but benefit from it. So the saline itself can be just a boon, but what we want to see is does it change the actual physiologic underpinnings underneath the illness process or the pathology? And if it changes it, can we do it in a sustainable way? Because that becomes really interesting, because now we have something that we can apply across scale for people, which would be super cool. So during the infusion itself, when people are resting, their heart rate was dropping about 11 beats per minute, systolic, diastolic pressure staying normal. We kind of like that. Hydration percentage didn't change, but this is an insensitive marker for that anyway. What was a little more telling was in the post tilt. Remember we said that was usually within about 9 days of the original hydration. We actually saw that the heart rate increment went up slightly compared to their original numbers, which isn't ideal. So we didn't see the kind of structural physiological changes or the functional changes that we would really hope to see if this was a type of intervention that had a long-term benefit for people. So that part's kind of a bummer, that we didn't actually see any positive outcomes in the physiology side of it. And then this is the patient-related experience, or the patient-reported experience, excuse me. And what this is kind of looking at was they just did like a really easy scoring. And it was like, to what degree would you want to come back? And I thought that part was interesting, because it was kind of like 42% said that they would come back, which means like it's at least not a net negative to them. They're getting free saline and coming every 3 weeks. They'd be interested in that. What was, I thought, more telling was this, of the people that completed it. So this excludes, 18 people, like half the people almost, that just decided it wasn't worth it to them. 53% of the people that finished it out said they were unsure, and 5% said no. So it's interesting to me that more than half of the people were not necessarily interested in continuing it. So that part is probably important. Because you just think of the incentive, like if you're someone that's not feeling well and you're getting free care and all you're doing is just going and getting an IV bag and filling out a form, but you're like, might not be worth it, then like the feels of that, maybe that's not what gets published and that's not what's in the data, but the feels of that is like people weren't like super pumped about doing this. And that could be for other reasons. It could be maybe they were all driving 6 hours to get there, or who knows, I don't know. But I think it's at least worth considering in the conversation. And then obviously post-exertional malaise, they had 14 out of 22 of them experience that during the course of the treatment, which is tough. But then that's part of the deal with ME/CFS patients, is like getting up and being around and like doing that type of event to what, even if it's a small degree, can be really hard on people. And I don't know, in my experience, I don't know that I would look at that and say like, well, if they're having that post-exertional malaise, then we shouldn't do it. For most people, they're going to have to go through some measure of that on the way to getting out of it anyway. So, that's kind of how I would tend to look at that. So things that we're thinking about: it's a high attrition rate. So you start at 40, then cuts to 22 that finished it, and then 19 that did all the questionnaires, and then 17 that did the tilt. The way that they implemented the surveys isn't necessarily perfect because of the recall bias. And then the single item anchors, so like that test where it's looking at could you return to work again, to do that on a 0 to 100 scale, what you're looking for is like, what do I do to get back toward optimum? And then how do we get to the physiology and feeling? This is kind of like you predicting if you could go back to work again. So that's kind of tough. It's like, do I also think I could win the lottery? I might. I can pick numbers pretty cool. I'm good with a pencil. So it's not like the best way to look at it. And then unfortunately, what we were really hoping for when in looking at that objective physiology change persisting over time, didn't really see that so much. And on a subjective basis, the patients were, voted, the burden's kind of bigger than the benefit was, which is too bad. So things I like that there is this ability to get a subjective improvement when we can improve the hydration, even if it's just blunt force, we're going to slam it in. At least the fact that like being able to get more juice in your head, or so we would assume, we obviously don't know. That's kind of what comes next in terms of what we should measure for these. But like by improving the overall blood volume, can we get more circulation? Can we improve how people feel? I like that sensation because then if we can say, hey, you know what? People do feel better if we can get the blood in their head, then to me that's great because it's like, well, then let's try to figure out how do we improve the mechanisms that should work automatically. How do we get them to go back to working automatically again so these people can tolerate a life of posture and movement and being upright again and having these beautiful reflexes that we all take for granted? How do we get those back? So seeing the subjective improvements is what I'm looking for. I'm actually like I'm on the side of rooting for these types of cases to succeed because I want to see these little glimpses in people where can you see these little changes in how they feel, and then how can you rethink that problem as far as trying to make it permanent. Okay. So the likely mechanism here is that there's a short-term hemodynamic shift, meaning that we're just putting more blood in the system, so it's easier to keep all of the vessels full. And the thing that I take away from this is that we're really looking at a neural circuitry error rather than true hypovolemia as a problem. So if it was true hypovolemia and you just expand the blood volume, if all of the control systems worked correctly, then just expanding that blood volume would be enough to let the motor run, and it would run. But we're seeing here that the relative hypovolemia that people experience because circulation is being mismanaged within the system points toward this regulatory component where the systems that should just automatically be controlling this thing that's going on, being able to like just send blood where we're trying to send it based on whatever our brain's trying to do, it's not quite kicking in. And that's kind of what this points to for me. So that's kind of like is further evidence in that perspective. Other people may interpret it differently. That doesn't bother me. But to me, that is the thing that one of the things I took away from this paper. So kind of zooming out, broader context, there have been a couple other cases over the years where people looked at this with similar kind of processes in their studies where they were looking at same thing with refractory POTS where intermittent saline helped, kind of a similar thing. It was a very similar outcome to the paper that we see here. The ME/CFS studies from Van Kampen, which I've alluded to before, I think are brilliant studies. They have really pointed to what we have also observed in practice, where we see this consistent level of reduced cerebral blood flow and hypocapnia in these cases, which indicate the probability of a neurovascular type of an onset for many of these cases. Doesn't mean everybody falls in the same boat. That's important. Just because everybody has that one label stamped on their forehead doesn't mean that everybody has the same process, but it's a way to start to try to zoom out and understand where to start from. In the future, it would be really nice to see if we could also blind the patients. What I mean by that is like you should probably have a group of controls that are getting a placebo, right? Where basically the IV bag's there, but then you just have like a little phantom tube that comes off and drains into a bucket, into a reservoir. And so like you feel like you're getting it, like the subject couldn't tell, but they're not actually getting the saline. And then you can start to compare them. I really think it'd be beneficial to look at each of these on an individual basis. So rather than clump all of these together, there might be more signal for the next paper and actually looking at the individual criteria of each case and saying, what is it about this case that responds? And then how do we start to to move in a direction that helps us help maybe that particular cohort better and peeling off a cohort at a time. And so for what that's worth, let me change this out real quick. And then randomizing the cases. And then I really think that we missed, I mean, obviously this was meant to be just a signal finding study. This isn't to be, I'm not trying to poo-poo the case or to criticize them in a negative way. I'm just mostly pointing things out where I think we could move the needle. I want to see these succeed. I would love to see these types of studies done with cerebral blood flow measurements, with the tilt table each time, being able to look at things in a little more concentrated way, looking at objective findings correlated to subjective outcomes, and then looking at more longitudinal studies, like what happens over time. So beyond the 9 weeks, what happens a month later or 2 months later, and then also looking at what are the potential downsides. So like by giving people saline over a period of time, do we find that anything else in the physiology changes because of introducing that saline into the system? So I think all of those things are useful. And then I wrote this define MCIDS, which is minimal clinically important differences. And this is basically the smallest change in a treatment outcome that a patient would identify as important and would signal a change in the way that you manage that case. And so basically, like when we look at these subjective outcome measures, we're looking at them, but we don't actually know what any of it means. Like we don't know if going from a 50 to 100 changes someone's life or makes no difference at all. So actually taking a step back and making sure that we're using research methodologies that help us like move in a clinically positive direction for cases, especially when we're using real life human people, not just subjects, right? They're people, so that we can kind of do the best for them and help understand how are we moving them toward a better quality of life overall. So that's just kind of my simple nuts and bolts of it. I'm just a fella, but so the takeaways: IV saline's feasible. There's some transient benefits, like immediately afterwards, people can feel a little bit better. We don't know to what degree because we can't see case by case. My suspicion is some people actually probably felt a difference and some people not so much, but when you clump them together, it kind of smooths out the relationship. And then obviously improvements in some of the methodologies. I was a little bummed to see that we didn't see any big changes in physiology. It allows us to kind of look at this with perspectives on understanding the neurally mediated components. Let's understand a little bit more about these reflexes. Let's dive in there. Makes me excited to continue down that road. I am super thankful for the people that do this research. It takes a lot of time. It takes a lot of effort. It takes a lot of planning. And so I'm super thankful for them doing it. They help people like me who are at the bedside every day, like on the floor with patients, be able to get a glimpse into what's happening at the research bench, which I'm infinitely thankful for. So I just want to say thank you to this team and then to everyone that's in the research world for taking on this work. And I'm curious to hear what'll come next. So we got another alert for their next bit of work. So excited for that. But anyway, so yeah, that's the basic breakdown: IV saline, ME/CFS, dysautonomia, and yeah, leave us a comment. Let us know what you think. Obviously, I think there's some people out there that have a nice benefit from using saline. Be very interesting to study those folks and understand that particular mechanism of what's going on for them. Dig into that and see where it's going to have a meaningful impact for people. So hope the video is helpful. Leave us a comment, share it. Help people. Thanks a lot. We'll talk to you soon.